Good evening. My name is Pamela Marcus with Akcea Therapeutics. Thank you for joining the Akcea Product Theater, in touch with patient needs, a treatment option for the polyneuropathy of hereditary ATTR amyloidosis. Please feel free to submit questions anytime during this presentation, as there will be a question and answer to follow. This presentation is sponsored by Akcea Therapeutics. The speakers have received compensation from Akcea, and this is not a CME program. We're pleased to be joined by three presenters tonight. Dr. Andrew Darlington. Dr. Darlington earned his medical degree at the Philadelphia College of Osteopathic Medicine in Philadelphia, Pennsylvania. He completed his internship and residency in internal medicine at the University of Florida College of Medicine. He completed his cardiology fellowship at the University of Florida and completed a fellowship training in advanced heart failure and transplant cardiology at Yale University. Dr. Darlington is board certified in internal medicine, cardiovascular medicine, echocardiology, nuclear cardiology, and advanced heart failure and transplant cardiology. Dr. Chafic Karam. Dr. Karam is the Associate Professor of Clinical Neurology at the University of Pennsylvania. Dr. Karam completed his medical training at St. Joseph University in Beirut, his residency in neurology at Mount Sinai, Beth Israel in New York, and did a fellowship in peripheral nerve pathology at Mayo Clinic in Rochester, Minnesota. Dr. Karam also completed a fellowship in neuromuscular medicine and EMG at the Partners Program at Harvard Medical School. And our third presenter is Lane, our patient ambassador. Lane is a retired architect, married with 2 children. Lane lives with her husband and son outside of Washington, D.C. Lane grew up with an awareness of family history of hATTR. She's very proactive in seeking out and staying abreast of developments in the treatment of the disease and any opportunities to help raise awareness in the medical and also the non-medical community. I'm going to pass this over to Lane. Welcome, Lane.
Thank you, Pamela. As Pamela was saying, I do have an awareness from a family history. My father was diagnosed with hATTR amyloidosis in 1963 in Charlotte, North Carolina. His symptoms were primarily severe polyneuropathy and GI issues that caused major weight loss, and he progressed dramatically as his reliance went from cane to wheelchair to being bedbound. He required 24-hour care. Fortunately, my mother, who worked outside of the home, was able to arrange her schedule to help care for him. And my father's twin sister, my aunt, lived with us and also helped care for him. My father had 2 first cousins who presented with symptoms very similar to his, but they were never officially diagnosed. Each of those cousins had a child, my generation, who also developed symptoms very similar to their parents and my father. When my father was diagnosed, there was no genetic testing and very little information about amyloidosis. So we didn't really know for sure that it was hereditary, but because of the family history, we suspected that it must be. I'm very aware that this disease can be difficult to diagnose, even when you do have and articulate a family history. In my case, I began to experience an array of seemingly unrelated symptoms, but they gradually began to become worse and have more and more of an impact all my life. In fact, by the time that I was diagnosed, I had to end my career as an architect. We suspect that my first symptoms were bilateral carpal tunnel, which I developed shortly after my daughter was born. I was in my mid-30s. But I was told at the time that it was very typical for women to develop carpal tunnel after childbirth, and also as an architect, because at that time we drew by hand. And even when we progressed to using computers, very many architects had carpal tunnel syndrome, but I had bilateral release surgery. It was difficult, especially with a small child, to manage with carpal tunnel, but the surgery did seem to take care of that particular symptom. Thought nothing more about it. I had been very healthy my whole life. And then in my early 50s, I developed a rapid heartbeat as well as breathing issues. You'll see on the slide that my rapid heart rate was discovered by my dentist, of all people, who for some reason began doing blood pressure and heart rate testing. Hadn't done it since, but nevertheless. And so he recommended I see a cardiologist, which I did. The cardiologist diagnosed me with cardiomyopathy and began to treat me for the more typical version of cardiomyopathy. But over the next 15 years, I began to develop additional symptoms of nuisance issues. I saw a pulmonologist for breathing problems. He thought I had asthma, which I didn't. I saw a rheumatologist who was sure that I had rheumatoid arthritis, but the testing proved that that was not the case. I began to have recurrence of the carpal tunnel syndrome, and the orthopedist who had treated me originally was just baffled, couldn't figure out what was going on. All of these symptoms, along with a sort of general weakness, finally caught up with me when I was about 50, and I fainted on the kitchen floor. Came to, went to the emergency room, which was a major thing for me to do because I had been generally so healthy. When I got to the emergency room, I had an alarmingly low blood pressure and heart rate. Had an emergency pacemaker implanted. This was on a Saturday, so on a Monday, when they did the surgery to do a more typical pacemaker implant, the physicians also did a heart biopsy because they suspected amyloidosis. And it was just sort of coincidental that the thought of amyloidosis came up, actually, as I came to learn. The diagnosis came back, yes, I had hATTR amyloidosis like my father had had, but mine had presented completely differently. Mine presented with the cardiac symptoms first. It was a bit of a relief to realize that there in fact was a disease, one particular disease that was an umbrella for all of these symptoms that I had been experiencing, and that there were people who knew what was going on and could give me some help. It was pretty devastating, though, to realize what was wrong with me, having seen my father, having seen the impact on our family, seeing how quickly he degenerated with this progressive disease. But at the time I was diagnosed, there was no treatment available for amyloidosis, and I really did feel that I had very little hope. At this time, I'd like to turn the presentation over to Dr. Karam for his next portion of our presentation.
Thank you, Lane, and thank you again for sharing your experience with us. I will now transition to talk about hereditary ATTR amyloidosis with polyneuropathy, the impact on quality of life, and the need for rapid diagnosis. Here are my disclosures. First, let's start. What is TTR amyloidosis, transthyretin? You know, there are several kinds of amyloidosis that can affect the human body. And TTR amyloidosis is actually one of the most common. The other one that is common, but it's a completely different disorder, is AL amyloidosis, which is caused by a plasma cells in bone marrow that produces an abnormal immunoglobulin protein. What we're going to focus this talk on is ATTR amyloidosis. This protein is produced by the liver. It has a function in the human body. It carries the thyroxine and the retinol, hence its name. And usually it exists as a tetramer. This is a picture that shows you how the TTR is produced and how it leads to this amyloidosis. Amyloidosis is basically when the protein misfold, aggregates, becomes toxic to organ, and deposit throughout the body. In ATTR, it mainly affects the heart and the nerve. But as you saw with Lane, very frequently people get carpal tunnel syndrome. Actually, it's one of the most frequent first sign and can precede the diagnosis by several years, and in Lane case, by almost 20 years. There's many different mutations, over 130 that has been described in the TTR gene, and the different mutations are important because the phenotype vary depending on the type of mutation. This is a picture that shows you the different type of mutation, the more common ones. The VAL50MET or V50MET is one of the most common throughout the world. It presents usually with a peripheral neuropathy, but many of these patients also have cardiomyopathy. On the other end of the spectrum, we have the V122I or VAL142I with the newer nomenclature. And these patients present with predominantly cardiomyopathy. But again, if you look carefully and if you follow these patients carefully, you'll find that many of these patients have neuropathy. And hence the transition from the usual nomenclature, classical, if you want, of familial amyloid polyneuropathy and cardiac amyloid polyneuropathy to more of hATTR, which really summarize and represent how patients present. So as we discussed, although it's a systemic disease, a lot of the patient experience neuropathy or cardiomyopathy. The neuropathy usually present with numbness, tingling, burning, pain in the feet. And as the disease progresses, it becomes to affect more the balance. It can cause dizziness for the patient, especially if there's autonomic involvement, which is actually also common. It's one of the red flags for this condition. People can have constipation, diarrhea, which can be really debilitating. Sometimes people cannot even leave the house because they're constantly soiling their clothes, vomiting, weight loss. Some of these patients get worked up for cancer because of the significant weight loss and how sick they look. People have trouble climbing stairs, tripping over their feet, and so forth. So many different symptoms that affect, that can present with these patients. The shortness of breath, swelling in the leg, exercise intolerance, and these can sometimes mimic asthma or heart failure from unknown origin. Very frequently, the ejection fraction is preserved in these patients. And again, as I mentioned, this is a mixed phenotype. You know, whenever you look at these patients, they may predominantly have cardiomyopathy because that's the major organ that's involved, but very frequently also have neuropathy. And the neuropathy sometimes can be pretty debilitating for these patients. So for example, the P-VAL142I and T80-ALA, which used to be called T60A, these are classically considered cardiomyopathy, but up to 30–50% of these patients can also have neuropathy. So that's why we like to see these patients, you know, between a neurologist and the cardiologist, try to have them see the patient, not necessarily at the same time, but kind of always trying to involve the other specialty to have a multidisciplinary approach for these patients. The polyneuropathy, as you can imagine, in these patients can be significantly incapacitating. Not only they can have numbness, tingling, pain, weakness, tripping over their feet, having trouble with their hands, opening jars and so forth, and then buttoning their shirt, but also they can have autonomic neuropathy, which manifests with orthostatic hypotension. Every time they stand up, their blood pressure drops. They can pass out because of that. They can have the alternating constipation and diarrhea. Erectile dysfunction is a frequent symptoms in men, and very early on it happens. Sweating abnormalities and urinary retention. The other characteristic of this neuropathy, it's not your run-of-the-mill neuropathy where people have burning in the feet and it stays like this for decades without really significant progression and causing disability. However, in these patients with hATTR, the neuropathy rapidly causes significant weakness where they cannot walk. They need a walker. Usually 5 to 7 years, people start using a walker. And after that, 4 to 5 years, depending on the type of mutation and how aggressive the disease is and the age of the patient, they become wheelchair bound. And we've had people on all the spectrum where only in 3-4 years they ended up in a wheelchair, and some people took 10 or 12 years and more to become wheelchair bound. The neuropathy can have a devastating quality of effect on the quality of life. As you can imagine, you not only have the pain, you also have the disability, you have the kind of the constipation, the diarrhea, the soiling that can be really embarrassing. So when you compare hATTR amyloidosis to other type of disease, such as diabetes, you can see that people are affected much more. And they're affected really similarly to when you have diabetes with severe complication of ulceration, gangrene, and amputation. So pretty severe disease. And it can be, as I just discussed, it's not only the numbness and tingling in the feet. That's not only the neuropathy, it progresses and causes a lot of issues. People can develop bed sores, muscle atrophy, DVT because they're not moving much, infection, sepsis. Some of these patients, because of the severe GI involvement, can look very malnourished. And of course, the autonomic involvement can cause arrhythmia and orthostatic hypotension, falls, and loss of consciousness. So when do we think about hATTR amyloidosis? Really, anybody with a combination of neuropathy, cardiomyopathy, carpal tunnel syndrome, rapidly progressive neuropathy that you don't really understand why the patient has neuropathy. There's really no reason that they have neuropathy, and any other evidence that there is multi-organ involvement. So vitreous opacities, renal abnormalities, the GI issue, diarrhea, constipation, and if they alternate, that's even more specific, the weight loss. And of course, if you have a family history like Lane, I'm really surprised how you do have, we knew your father had the mutation, and yet your diagnosis was really significantly delayed. Some other thing that we see also, tendon rupture, usually the biceps, and spinal stenosis. Unfortunately, these are common as such as carpal tunnel syndrome. But one thing that I like to point out, and Lane mentioned this, whenever you have carpal tunnel syndrome that recurs, so you had the surgery and everything went well, and the carpal tunnel came back, that should be a red flag. Or if the carpal tunnel, the patient undergoes surgery, but they continue to progress with atrophy and weakness in the hands, that's another red flag. So what are things that we ask when you have patients and you suspect that they may have it? Of course, do you have evidence or history of amyloidosis or sudden death in the family from heart failure on, if they have a diabetic neuropathy, but it's really acting aggressive and progressing, which is not usually seen in diabetic neuropathy, then you should rethink, maybe there's something else going on. If you have CIDP or chronic inflammatory demyelinating polyneuropathy, the patient is getting IVIG, steroid, and they're not getting better, then also we have to revisit the diagnosis and look for hATTR. And of course, if you have just idiopathic neuropathy, the doctor already did the screening for diabetes, vitamin B12 deficiency, monoclonal protein, and all the workup is negative, and the patient gets diagnosed with idiopathic neuropathy. However, if it progresses to the point where the patient having foot drop, they're using a walker, they also have carpal tunnel syndrome or heart failure, then you should really look for hATTR in that case. And it's really just a genetic testing, which is easy to obtain and free of charge. So in regard to the cardiac issue, if you suspect cardiac amyloidosis, the first thing that you need to do is to make sure the patient doesn't have AL amyloidosis. So you just do immunofixation, SPEP, and free light chain. And depending on the results, if they're positive, then you have to really rule out cardiac amyloidosis from AL. If you rule that out, then you have to test the patient for TTR, because people, especially at an older age, can have MGUS and they can have hATTR. So it doesn't rule it out. You can have both. I think the major challenge is, or the major, I think, mistake that I've seen rarely, but it's been done, where people assume that the amyloid in the heart is caused by AL and the patient got chemotherapy, whereas they actually had hATTR. So be careful with that. Once you rule that out, you do a PYP scan, and the PYP scan, if it's grade 2 or 3, then it's almost diagnostic of TTR. And then you have to figure out, is this wild type TTR or hATTR? And then you do the genetic testing and look for neuropathy and so forth. So genetic testing, I'm a big fan of genetic testing because it's a quick, not really invasive test, and it can give you a lot of answers. It can differentiate between wild type ATTR and hATTR, of course. Genetic counseling is a good thing to do. You can do it yourself, or you can have somebody who's an expert genetic counselor do these, because they can impact the disease management decision and have important implication for the patient's family. So you'd consider genetic testing and counseling when you have a positive biopsy or PYP scan for amyloid, if the patient have a mixed phenotype, if there's family members, if you're looking for founder population, especially if people are from Portuguese and Irish population. But in the US, African American, very frequently, it's estimated that 3% of them carry the V122I mutation. And then, of course, when, as we discussed, progressive form of neuropathy without really good explanation. So due to the progressive nature of this disease, the earlier you diagnose the patient and the earlier you start treatment, the better they're gonna do. I've seen people where they have neuropathy, but the neuropathy is not very bad, and they say, well, let's wait, and then we can start treatment later. That's a mistake, because the amyloid is accumulating, and the more it accumulates, the more damage it causes. So the earlier we treat, the better it's gonna be. And then once you diagnose the patient, of course, doing the genetic testing, because you don't wanna diagnose somebody who's wild type when they have hATTR and so forth. So that being said, happy to take question later, but I will transition back to Lane.
Thank you, Dr. Karam. When I was diagnosed in 2011, I also had genetic testing done. But it's interesting that I had no obvious signs of polyneuropathy other than perhaps the carpal tunnel syndrome that I had had previously. But as I mentioned before, and as Dr. Karam mentioned, my bilateral carpal tunnel syndrome did return. And then, as the years passed since my diagnosis, I did begin to develop GI and polyneuropathy symptoms. The GI issues are really terrible. They do affect you in all ways. They affect you socially. I know several other hATTR patients who have similar GI issues, and we do joke that we know where all the public bathrooms are. It's a tough one to manage. My gastroenterologist has been very helpful, but the truth of the matter is there's not much that can be done other than treat the symptoms. My symptoms were severe constipation alternating with diarrhea and the lovely fecal incontinence, which is always a difficult thing to manage. But I did begin to develop polyneuropathy in my feet and legs. I remember vividly where it started in the balls of my feet, and I could feel it move up my legs. Because of this polyneuropathy, I developed real balance issues. In the beginning, I used to say I felt like a ship listing as I went up the stairs. I had to hold handrails for sure. But as Dr. Karam also mentioned, I did the tripping over my feet. I had several falls, broke my arm, broke a couple toes, had lovely bruises on my face and arms from these falls. And at this point, I did begin to see a neurologist because I was concerned about the possible progression of this disease. Once again, having seen it in my father. All of these symptoms really did have a negative impact on my life. As I mentioned earlier, I had to end my career as an architect, and that was hard. That was very difficult. Not only were the symptoms preventing me from enjoying the freedom and flexibility of activities and that I had enjoyed with my family and friends, but the emotional burden of knowing that there was really no treatment was taking a huge toll on me. The disease had begun to affect my identity for myself. I could not imagine the future. I remember being in a place where I couldn't even watch previews for upcoming movies. I'd love to go to the movies because I didn't know if I would make it until the movies came out. That sounds really dramatic, but it absolutely is true. My mother probably took this the hardest because she had cared for my father, and now she saw it affecting me. Tremendous emotional impact on my family, not to mention the financial impact from having to give up my career. At this point, I'd like to turn over to Dr. Darlington, who's going to take us through the next section of the presentation.
Well, thank you very much, Lane and Dr. Karam. I have two tough acts to follow, but hopefully over the course of the next 25 or 30 minutes, we can expand a little bit more on what has been introduced to you and spend a little bit more time talking about the drug therapy that's available, mechanism of action, potential side effects, etc. So I think it will be a nice way to round out the discussion. So this is just a brief slide. There's a lot of verbiage here. We will highlight it here and then expand on it a little bit later. But what this is just a simple warning regarding two potential side effects that can be seen with the therapy itself. I will mention that these two potential side effects, thrombocytopenia and glomerulonephritis, are uncommon. They were seen in the NEURO-TTR trial at about 3% of the population studied. But just highlighting the thrombocytopenia, the drug itself, TEGSEDI, can cause reductions in platelet count. And in the clinical trial, we saw a drop in platelet count under 100,000 in about 25% of patients. It is also important to note that the drug is contraindicated if the baseline platelet count is under 100,000. And we'll highlight the importance of monitoring platelet counts during the course of drug therapy, in particular as it pertains to the REMS program highlighted below. As it pertains to glomerulonephritis, once again, this is a rare side effect of the drug therapy, but it can cause glomerulonephritis that in turn requires immunosuppressive treatment, and in one particular patient required dialysis-dependent renal failure. So it is very uncommon, but at baseline, screening is done, particularly with a urine protein creatinine ratio. And if that ratio is greater than 1,000 milligrams per gram, the drug is not to be initiated. And just like with monitoring for thrombocytopenia, the same degree of monitoring occurs for glomerulonephritis during the course of drug therapy. And as I had highlighted previously, this monitoring is done through a risk evaluation mitigation strategy program, or REMS program, which all providers that treat patients with TEGSEDI have to go through in order to provide drug. We'll highlight this a little bit later in the discussion. These are my disclosures. So what about the drug therapy itself? How does it actually work? The mechanism of action, I think this is critical. So it is a silencer drug. It's an antisense oligonucleotide that is basically synthetically generated, and it binds via the Watson-Crick base pairing method to the messenger RNA of the TTR that is created from the TTR gene. And you can see that highlighted on your slide in front of you. And basically, by the means of a ribonuclease, it digests that messenger RNA and reduces significantly the degree of TTR protein that is made. And we'll talk a little bit more and show a slide in regards to how impactful this drug is in reducing the production of the TTR protein itself. So let's talk a little bit about the NEURO-TTR trial itself. You can see the design laid out here. And just to highlight briefly, there were 173 adult age patients. You can see the ranges of age there with mild to moderate symptomatic polyneuropathy from hereditary ATTR. And I think this is key. These are patients with mild to moderate symptoms, not severe symptomatology. And you can see their neuropathy impairment scores reflect that much. They were screened and then subsequently randomized unequally 2-to-1 to drug therapy versus placebo. And patients on drug therapy were given Tegsedi subcutaneous injection once weekly for 15 months. And the co-primary endpoints are listed above there, and there are co-primary endpoints. One, the modified neuropathy impairment score +7. We'll talk a little bit about that in a second. And the Norfolk Quality of Life Diabetic Neuropathy Total Score. Subsequent to the completion of the study itself, then patients were offered the opportunity to enroll in the open label extension, which has been ongoing for up to 5 years of additional treatment. So at this point, all patients, whether they were randomized to Tegsedi or placebo, are receiving drug at this point in time. So let's delve in a little bit more to the co-primary endpoints themselves. For those of you that are not familiar, most of us are cardiologists in the room, so this will be a nice overview. The modified neuropathy impairment score +7 ultimately is a objective way to assess very specifically the impairment that neuropathy has on these patients with hereditary ATTR. And it specifically drills down the sensory motor dysfunction as well as the autonomic dysfunction that can occur with these patients. And they are assigned a score. And the score, ultimately, the higher it is, equates to lower function and more dysfunction as it relates to neuropathy. On the flip side, the Norfolk Quality of Life Diabetic Neuropathy Score is a questionnaire that is assigned to the patients. Ultimately, numerous questions over 5 different domains assessing the impact on quality of life this disease process has on this patient population. And once again, a higher score equals a poor quality of life. So these were the 2 co-primary endpoints that were assessed over the course of the 15 months of the trial itself. So what about the patients themselves? I think it's very important in any clinical trial to be aware of who you're actually studying. And you can see that displayed here. These were adult age patients, typically in their 5th and 6th decade of life, spread all across the world, smatterings in Europe, North and South America. And of the 27 different mutations that were assessed during the clinical trial, the predominant mutation was the V50M mutation, which is the most common mutation that we see in the world. And typically is seen in patients with polyneuropathy. The disease stage that I highlighted earlier, typically these were patients in stage 1 or stage 2, so mild to moderate impairment. You asked the question about whether or not perhaps these patients had cardiac involvement. Well, you can see there was a very high prevalence rate of patients that had coexisting cardiomyopathy in the trial as well. So roughly about two thirds of patients had coexisting cardiomyopathy. And you can see their baseline mNIS +7 and Norfolk Quality of Life scores at the bottom of the slide. So what about the primary endpoint? You can see that displayed here on left and right. What you're looking at on the left is the mNIS +7 score. Remember, higher point scores signify more impairment as it pertains to neuropathy, and a 2-point difference is considered significant. You can see in the Tegsedi group on the left, there was a slight degree of progression on average, but relative to placebo, a significant difference as assessed by the mNIS +7 score. So as it pertains to sensory motor dysfunction and autonomic dysfunction, there is a significant difference in patients treated with drug relative to placebo. And I would highlight once again that this is a trial that went for on average 15 months, so relatively short in nature. On the right, you can see the Norfolk quality of life outcomes. Once again, a higher point score is associated with more significant subjective impairment by this questionnaire in patients on drug versus placebo. And you can see once again a significant difference between the two groups over the course of the 15 months of the trial. Highlighted at the bottom is that nearly 50% of patients that were on drug actually saw improvement when on drug. And I think that is also very important to highlight, because this disease process, once it takes hold, it is relentlessly progressive. And this was, highlighted earlier in the discussion. So returning back to a little bit on the safety information itself, once again, I think this is important to highlight. The drug itself at baseline is contraindicated in patients with platelet counts under 100,000, a history of acute glomerulonephritis caused by the drug, or a history of hypersensitivity reactions to the drug itself. So I think it's important to commit these simple things to memory when you're potentially anticipating starting drug therapy on patients. So the next couple of slides, you're going to see graphical representations of the endpoints, including the open label extension, which is what you're seeing here. So you can see on the first part of the graph on the left, the actual randomized phase of the study, and then to the right, the open label extension. Patients on drug in the purple denoted line, you can see over time, their MNIS scores gradually progress. But the important point here is relative to placebo, still a significant difference that extends into the open label portion of the trial itself. The other important point here is when you look at the crosshairs of when patients enter the open label extension and go from placebo to drug, which you see in gray, they seem to balance out and steady out over time, but still their degree of impairment is significantly different than those patients that were started on drug just 15 months prior. There we go. Sorry about that. So this looks very similar, but what you're looking at here is the Norfolk quality of life outcomes, the other co-primary endpoint in the NEURO-TTR randomized arm, and then ultimately in the open label extension itself. And once again, patients that were started on Tegsedi, sorry about that. The slide deck just got a little bit away from me. Give me 1 second. Okay, there we go. So once again, it mirrors what we're seeing in the MNIS +7 score. Here it is, the Norfolk quality of life. And patients that are delayed and started on drug at the onset of the open label extension see stabilization in their Norfolk quality of life scores, but once again, does not come back to baseline what we see in patients on Tegsedi itself. So I think the important takeaway point here is identifying patients early and starting on drug therapy early as well. Once again, coming back and highlighting a little bit more on the thrombocytopenia itself. So Tegsedi, as I had mentioned, does cause reductions in platelet counts that can be sudden and unpredictable, and if not monitored, can be life-threatening. In the trial itself, as I had mentioned, roughly 25% of patients did have a drop in platelet count under 100,000 compared to 2% of patients on placebo. The number of patients that had platelet counts under 75,000, though, was in a smaller percentage, 14%, compared to no patients on placebo. One individual patient in the clinical trial did experience a fatal intracranial hemorrhage. I think it's important to highlight in this particular scenario, this is before the significant monitoring that goes on now with the REMS program was applied, but there was one individual patient that suffered that. It's important to also highlight that we are not to initiate the drug with a baseline platelet count under 100,000, and very important to follow the monitoring, which we'll highlight in a little bit. Some of the secondary endpoints, which you can see here in the NEURO-TTR trial, are listed below. The Norfolk quality of life diabetic neuropathy symptom domain score in patients with stage 1 individually, and physical functioning large fiber neuropathy domain scores in patients with stage 2 polyneuropathy. Remember, once again, these are patients that were all in either stage 1 or stage 2 in this trial. There were no stage 3 patients. Once again, highlighting the importance of identifying and treating these patients early on. The modified body mass index, which accounts for albumin, and the body mass index was assessed as well. The NIS score plus the modified NIS score plus 7, which are slightly different in assessments and a little bit more specific and ultimately utilized in the MNIS plus 7 score that we saw in the trial. And then analysis of secondary endpoints. It's important to note that they showed statistically significant difference in favor of Tegsedi at 66 weeks for the majority of measures. Certain measures such as BMI and modified BMI did not show significance. So this is important if you want to know ultimately how this drug actually works in regards to its impact on serum TTR levels. You can see here the median % change from baseline in the serum TTR over time, placebo in gray, drug therapy in purple here. And you can see that significant reductions in serum TTR occur rather quickly when patients are exposed to drug, reaching nearly 80% of their baseline and levels that are sustained when patients were remained on drug over the course of the trial. So significant reductions that occur rather quickly. How about shifting gears a little bit more and highlighting the glomerulonephritis aspect? Once again, very uncommon in the clinical trial itself, but it can occur, and in one particular patient led to dialysis-dependent renal failure. In the trial itself, just 3 patients or 3% of Tegsedi-treated patients compared with no patients on placebo developed glomerulonephritis. Very important to note that if glomerulonephritis is suspected, pursuing prompt diagnosis and initiating treatment as soon as possible is imperative. And it's very important, and we'll highlight once again the recommended monitoring frequency and treatment recommendations for the various renal parameters. The drug itself, Tegsedi, should not be initiated in patients with a urine protein creatinine ratio in excess of 1,000 milligrams per gram or greater. And once again, if at any point in time during treatment glomerulonephritis is actually confirmed, the drug should be permanently discontinued. And I will say that this is done very fluently and very efficiently through this REMS program. As a provider of this drug over the course of the last year now, I can say that it has proven to be very effective at managing patients and monitoring patients on drug therapy. What you're looking here is at a secondary endpoint, and you're observing the short form 36 questionnaire. Once again, actually a tertiary endpoint in the trial itself. And what it is a non-disease specific measure of healthcare related quality of life as well in patients on drug therapy relative to placebo in the actual randomized phase, and then in the open label extension arm that you see as you move from left to right. And on this particular graph, as assessed by the short form questionnaire, the drug patients are on top in purple, and you can see the maintenance of their status scores over the course of not only the randomized arm of the trial, but also the open label extension. And in gray, you can see patients on placebo initially transition to drug therapy, see stabilization in their scores as they enter that open label extension. So, but once again, you can see that the degree of impairment in these patients switched late is still greater than those patients that were started on drug therapy from the very beginning. So it mirrors what you're seeing ultimately with the MNIS plus 7 scores and the Norfolk quality of life. So what you see here in the last graphical representation of the NEURO-TTR trial are results from the short form questionnaire, the individual actual endpoints that were looked at, some of them, and you're looking at the change in the percentage of patients showing substantial impairment as assessed by this questionnaire. And once again, in purple are patients on drug, gray on placebo. And you can see from left to right, you have consistency in the percentage of patients showing significant difference, regardless of the aspect and the functional item assessed, different for patients on placebo relative to Tegsedi. So whether it be something like climbing stairs, bending, kneeling, stooping, walking a certain 100 yards or so, bathing or dressing, etc., all consistently more patients on placebo show significant impairment over the course of time relative to drug therapy treated patients. Just a little bit more on safety. There was one patient in the trial that experienced a carotid artery dissection and stroke. So I think it's important to educate patients as well on potential symptoms of stroke. and central nervous system arterial dissection. So important as well, of course, that this is identified or suspected, that they are approached and treated appropriately. Inflammatory and immune effects, we highlighted a couple of these for the last couple of minutes: glomerulonephritis and thrombocytopenia. Once again, this can occur. And in the trial itself, there was one single case of anti-neutrophil cytoplasmic autoantibody or ANCA positive vasculitis. So it's very important to note as well that these inflammatory and immune changes can be an effect of the class of drugs themselves, not just with Tegsedi itself. What you see here is the clinical safety profile of the drug itself. For the most part, these are adverse reactions that are mild in nature, the most common being an injection site reaction, typically occurring when it does early on in initiation of the drug itself. With the exception of potentially thrombocytopenia, though, most of these adverse reactions are mild in nature and self-limiting, but you can see here numerically higher in a number of these patients on drug relative to placebo. This is a very important slide. The open label extension, I think, was critical. This, as I had mentioned, is a phase of this trial that went on for up to five additional years. And the important point here is that there were no additional cases of significant thrombocytopenia, defined as grade 4 thrombocytopenia, less than 25,000 platelet count, or glomerulonephritis in this open label extension. So no further cases were assessed over the course of up to 5 years in the open label extension. There were patients that discontinued drug and placebo. You can see that there, 18% in the Tegsedi arm and just 8% in the placebo Tegsedi. There were serious treatment emergent adverse events that occurred in patients on drug and in placebo, but importantly, it's really key to look down here and see that it's really not related to treatment, but a small smattering of these particular patients. And 9 fatal adverse events occurred during the extension phase, but none were directly related to treatment itself. And I think this just highlights how sick this population actually is. So I think that's important to highlight. So what about the REMS program itself? I think this is also very important. We've been highlighting this periodically over the course of the last 15 or 20 minutes or so. This is set up as a safeguard put in place to help mitigate the potential risk of serious bleeding due to thrombocytopenia and or glomerulonephritis in patients that are on drug therapy. So every prescriber of the drug has to certify through the REMS program. The pharmacy is certified and the patient is enrolled through this program as well. And when patients ultimately are enrolled, they are committing before starting treatment to handle the actual monitoring phase of this, which we'll highlight in just a second. And throughout the course of treatment, there are status forms, patient status forms that are done every 90 days to confirm that the individual patients are continuing treatment. So this safeguard has been put in place and utilized very effectively to allow our patients to get life-saving drug in a safe and effective fashion. So how are they actually monitored? At baseline, as I had mentioned, serum platelet counts are drawn, serum creatinine to assess GFR, protein creatinine ratio, urinalysis, transaminases, total bilirubin. During the course of treatment, every week a platelet count is drawn, and we'll highlight how easy this actually is in just a minute. Every 2 weeks, serum creatinine, GFR, urinalysis, and protein creatinine ratios are done. Liver enzymes, total bilirubin are done every 4 months. And this is done once again to ensure the safety of our patients that are ongoing with drug treatment. Just a little bit more on liver impairment. It occurred in small numbers. About 8% of patients did see a modest elevation in ALTs, 3 times the upper limits of normal, compared with 3% on placebo. An even smaller percentage saw higher levels of ALT elevation compared to placebo. So as you had seen, we highlight and monitor liver enzymes every 4 months when patients are on drug therapy. And if at any point in time there's concern for hepatic dysfunction, it's important to measure these transaminases, total bilirubin, and interrupt or potentially completely discontinue therapy as appropriate. Just to highlight on liver transplant, there have been cases of liver transplant rejection that have responded quite nicely to systemic steroids, allowing normalization of transaminase levels. So I think that's very important to note that it can occur, but readily treated by steroids. Very, very important that if patients are having a liver transplant and are on drug therapy, these LFTs are monitored monthly as opposed to every 4 months. and if there's concern for rejection, drugs should be discontinued. Just kind of tying up here on the safety information here, the hypersensitivity reactions can occur. You can see also in small numbers, roughly 4% of patients. Important to note, if you suspect a hypersensitivity reaction, drug is to be discontinued. What does occur fairly commonly is uninterpretable platelet counts due to clumping between the antiplatelet antibodies and the EDTA. We do see this from time to time in clinical practice, and in the trial, 23% of patients had at least one uninterpretable platelet count. The key here is that if you see this, you're ultimately instructed to hold drug. You'll hold drug until you can actually obtain a platelet count that is interpretable above 100,000, so drug could be continued. So this very well may happen in your clinical practice, but it's just important to know that you're holding drug until you get an actual platelet count that you can interpret and utilize for your patients. Based on the mechanism of action, we know that TTR is a carrier protein for vitamin A and thyroxine. And so it's very important to note that vitamin A levels can drift down during treatment. So supplementation with the daily recommended allowance of vitamin A is recommended during the course of treatment for these patients. So one of the things that I really do enjoy about utilizing this drug is the convenience of it. There is one dose. It's self-administered at home, and it's once a week. So it's very simplistic for the patients and for the providers themselves. And it's in a pre-filled syringe, as you can see here on the screen. And I'm sure Lane will be able to highlight a little bit more about that in her experience with things. But it's important to note that really this is a fairly simplistic way to approach our patients for treatment once a week, same time every day during the week, can be administered at home. They do not need to come in for an infusion every 3 weeks. So it really is convenient for the patients themselves. And how does the actual Akcea Connect work to help support the patients? Once again, I'm sure Lane can highlight on this even more, but it does more than just help get drug for patients. They help with the self-injection training, navigate the waters of reimbursement for the drug therapy itself, really try to meet the patients financially so they can secure drug for them at a reasonable, if no cost. And they really do share in the commitment of the patient safety. And I think that's highlighted through the REMS program itself. And we've had just a wonderful experience over the course of the last year or two in our patients that are on drug. And I think things have worked out very well. Just a little bit more on the adverse reaction as we tie things up here. We have highlighted the glomerulonephritis aspect, the thrombocytopenia, et cetera. But it's just important to know that once again, most of these side effects that can occur are mild in nature. You saw on the one screen, the injection site reactions are perhaps most common, but also things such as nausea, headache, fatigue, et cetera, can be seen. One of the questions that will come up is that, well, ultimately, if we have a drug that can cause thrombocytopenia, what do we do with our other therapies, antiplatelets, anticoagulants? I think it's important to note that you can still ultimately use these therapies. It's just important to practice medicine and to ensure that you're taking care of your patients and you're monitoring your patients appropriately. But ultimately, we still continue on with antiplatelets and anticoagulants with patients on Tegsedi. And the same thing applies for the risk of glomerulonephritis and renal toxicity. It's just caution that should be applied when using potentially nephrotoxic drugs or the drugs that can impair renal function when you have a patient on Tegsedi. This is highlighting Akcea Connect once again, just that shared commitment once again. I think the company has done such a great job in regards to helping patients secure drug, education, scheduling follow-ups, ensuring blood draws are done in a timely fashion so patients can receive their drug on a weekly basis. The peer mentoring program is also an option for patients. I think whenever you're dealing with an unusual disease process that is perceived to be rare, I think there's a certain sense of fear that sometimes comes across, and it's always nice to have mentors that have similar experience living with the disease process, and that's available for patients ultimately exposed to drug as well. So I think at this point, I'm going to let Lane finish up her end, and then we'll go through a case study.
Thank you, Dr. Darlington. So I began taking Tegsedi in June of 2018. I can't tell you how excited I was to know that there was some treatment available to me for this disease. Previously, I had known of none, you know. So this was very exciting. And I have been using Tegsedi since then. It's very easy. It fits well into my schedule. I have traveled with it. I have a little, very small cooler that I put it in to take it with me. And it's just not an issue at all. Very simple, very easy. I do have injection site issues, bruising, bleeding. The big one is you get a burning sensation with the injection, or at least I do. Some people do, but it's not a big deal. I describe it to people who are just starting on Tegsedi as something akin to the kind of quick pain you might feel when you get a lidocaine injection. It's a different sort of pain, but it's about that sensitivity. Normally, even before taking Tegsedi, my platelet count tended to run on the low side of normal. So these weekly labs are really important. They're really critical. And I appreciate that the fact that with the disruption we have now with the COVID virus, a mobile phlebotomist comes to my house once a week. It's terrific, no problem. I have only had to go into the lab twice since March. And that was because I did experience the clumping that Dr. Darlington was talking about and had to go for a repeat lab. I am really appreciative that I have something as simple as these injections that I can do at home that makes such a difference. And I also appreciate the ability to connect with other hATTR patients through both the Connect program and the larger amyloidosis community. I discovered the support groups through Facebook, believe it or not. It's a tremendously wonderful thing. Every other year in Chicago, they have a large meeting. One this last year was canceled, of course, because of the disruption. But I look forward to going to these and talking not only with the other patients and their caregivers and families, but also with the experts on this disease. It's just a wonderful opportunity to get to hear how other people are dealing with the disease, what they've learned, what they know. And it's always a very positive experience. As was mentioned earlier, I do have 2 children who are adults. My daughter is 33 and married and very interested in starting a family. So through the availability of testing with the Connect program, she was able to have free testing last summer, and the results came back that she did not have the mutation for the disease. That was wonderful news. My son, who's 29, still lives at home with us. He's asymptomatic, and as you know, we've talked to genetic counselors. We were really anxious to find out the appropriate thing to do for testing for him, realizing that the emotional burden of finding bad news is also something you have to steel yourself for. At this point, he's not been tested, but I imagine that we will take advantage of this opportunity. He will take advantage of this opportunity in the near future. I'm anxious to do everything I can to help people who have this disease and their families learn about the available support systems and the information out there. I didn't have this when I was first diagnosed, and it's a pretty lonely place to be. I don't want their families to have to go through the worry, and you certainly don't want people Googling it because you can find some horrifying information. So I am happy to be able to participate in programs like this one, where we can help raise the awareness of the disease and help people who will be diagnosed in the future. Thank you. I appreciate that. And I'll turn this back over to Dr. Darlington as he will present a case study.
All right. Thank you very much, Lane. And we're going to finish this discussion before the question and answer session, highlighting a patient case study. And it really will, I think, kind of resonate with the audience here, hopefully. So this is a 79-year-old African-American male. You can see his past medical history listed here at the top, and highlighted already, you can see are some red flags in his history. Atrial fibrillation, bilateral carpal tunnel syndrome, lumbar spinal stenosis, peripheral neuropathy. So certainly a lot of red flags right off of the bat. So I think the important point here is you've got to think about this, you know, as a differential in your differential, or I fear that we'll miss it more often than not. But if you're thinking about it as part of that differential, I think you'll be more adept at making this diagnosis early on. You can see the referral history. It's pretty extensive and I think fairly typical for what we may see in clinical practice. Back in 2010, this particular gentleman saw an orthopedic surgeon for his bilateral carpal tunnel syndrome release. Once again, bilateral, a big red flag there. He then subsequently followed up with his primary care physician for lower back pain in 2016 and actually went back to the same orthopedic surgeon for a pre-op lumbar spinal stenosis surgery and sees a cardiologist to get cleared for this preoperative lumbar spinal stenosis surgery. So you can count here 1, 2, 3 different providers already that have touched this particular patient, and that is very common for what we see in clinical practice. So this goes by, and then a year later comes back to cardiology with new onset atrial fibrillation, and then finally sees neurology post the diagnosis in 2018. So you can see here a highlight of about 8 years between when this patient actually first presented with symptoms attributable to the disease process, and then ultimately when the diagnosis was actually made. And then once again, the number of different providers that actually touches this patient across multiple different specialties. We highlighted the red flag symptoms in this particular case. You can see it on the left. This guy checks all the boxes. Cardiovascular manifestations, there's AFib there, the spinal stenosis, the carpal tunnel, and of course, the peripheral sensorimotor dysfunction, the neuropathy there. So when this particular patient presented specifically to cardiology, you can see a highlight of what was performed. I had mentioned that he presented with rapid atrial fib, but also concomitant decompensated heart failure with the typical signs and symptoms you can see listed. Chest pain and palpitations had also been going on for several weeks prior to the presentation. An echocardiogram, of course, is done. And I think the key here is that you're seeing left ventricular hypertrophy that is, quote unquote, out of proportion to the represented voltage on EKG. I think most of us in the room here are willing and able to identify low voltage, low QRS voltage on the EKG, but more commonly, what we see is that disproportionate LVH relative to the voltage on EKG. So it may be very common to see normal voltage on EKG, but just not representative by the degree of LVH you see on echo. Diastolic impairment is almost universal for these patients, and there was grade 3 or restrictive diastolic impairment in this particular gentleman with the classic apical sparing pattern that we're so used to seeing on strain imaging, all of this on echo. And as Dr. Karam had mentioned, it's very important upfront when you anticipate that you're dealing with cardiomyopathy related to amyloidosis that you roll out light chain. We do not want to be treating patients potentially with TTR, with chemotherapy, or vice versa for that matter. So free light chains and immunofixation were done. You can see the reference ranges and the results for the kappa and lambda light chains, just as importantly as that ratio, and all are within normal limits. So then we proceed to imaging, and I think it's also important in 2020 now, we can make this diagnosis non-invasively. I think some people may potentially still feel that tissue diagnosis is 100% mandatory to make this diagnosis, and though we still do that, I think we can actually make this diagnosis pretty readily in a non-invasive fashion. And that is done ultimately by combining the blood work that you see here with the technetium pyrophosphate scan. So for those of you that are familiar, this is an old testing modality that we used for bone scans and infarct imaging decades ago, but has really experienced a rebirth in amyloid imaging. And the technetium pyrophosphate, when coupled with negative or normal free light chains and immunofixation, is nearly 100% sensitive and specific to make this diagnosis in a non-invasive fashion. So we're looking for grade 2 and grade 3 scans, and this particular gentleman had a grade 3 scan. So high uptake in the myocardium relative to bone. And his heart to contralateral ratio, which is more of a quantitative way of assessing this, was greater than 1.5, which is considered, once again, highly specific, in his case, 1.9. Then finally, assessing genetics, you can see here, tested positive for V142I, which is the most common mutation that we see in the United States. Classic cardiomyopathy, but important to note that these patients can present with a blend of polyneuropathy as well. It really truly is a zebra with many different stripes. I mean, we have patients with similar mutations, even within same families, that may present phenotypically different, if at all. And then finally, the neurologic assessment. I think it's important to note that this particular patient was being treated by his primary care physician for lower extremity weakness and pain. And I think the highlight here, which has been going over again and again, is that this neuropathy is progressive. It's relentlessly progressive when it's untreated. And that was what we saw with this particular patient. And then ultimately diagnostic testing was done there, nerve conduction studies and EMG showing prolongation of both median motor and sensory latencies at both lower extremities. So that progressive nature is another red flag. So this may seem very easy now that we've spent the last hour going over this, but in clinical practice, once again, I think it's very important that these patients will present littered with potential clues that you can piece together and make this diagnosis rapidly and effectively so we can potentially offer treatment for our folks. So what's important here? I think number one, it's important to note that polyneuropathy is a common manifestation of hereditary TTR amyloidosis with significant morbidity that drastically impacts patients' quality of life. And Lane really gave us firsthand evidence and how this has impacted her life. So I think that resonates. The rapid progression is key. I don't think we can mention that enough here. The rapid progression with polyneuropathy in particular underscores the importance to make this diagnosis so we can treat early and effectively. Know the red flag symptoms. If you don't identify them, we'll never make that diagnosis and ultimately never be able to offer treatment. In terms of drug therapy, Tegsedi is actually the first and only self-administered subcutaneous treatment for the polyneuropathy of hereditary TTR amyloidosis in adults, and delivered significant sustained improvements compared with placebo in that mNIS+7 score, that objective assessment of neuropathy, as well as in quality of life. Be aware of the thrombocytopenia and the glomerulonephritis. Though uncommon, it's important that these patients are being followed in the REMS program itself. And Akcea Connect, once again, is here to provide support and reliable resources the patients can actually trust. So I think that ends the actual discussion part, and I think this is probably where we move into the questions.
Thank you very much, Dr. Darlington. So in summary, polyneuropathy is a common manifestation of hereditary ATTR amyloidosis with significant morbidity and dramatically affects patients' quality of life. So I'd like to take some questions. We did have a few questions come in. The first one, if either presenter could comment on additional use of Tegsedi in patients on tafamidis.
I think that's probably going to be for me. I think that's a great question that comes up more often than not, probably one of the more common ones. And I think where we are right now with dual therapy is that we just don't know. We don't have data that ultimately compares patients that are on dual suppressive therapy, a stabilizer and a silencer. This is an area of active research, but at this point in time, we do not have available data to really suggest that, you know, one over the other or the combination therein actually impacts outcomes. But I think we're just really at the beginning stages of where we delve in with these patients with cardiomyopathy and polyneuropathy. And I think we'll learn a significant amount as we have new trials that are coming to date over the course of the next couple of years. But as of right now, it's still an area of active research.
Thank you. The next question, when an hATTR patient is sent to a neurologist for an evaluation of polyneuropathy, what constitutes the key diagnostic tests needed to identify amyloid polyneuropathy from other diagnoses? And what should the neurologist report back to the cardiologist?
So that's a great question, and I typed, and I'm happy to also answer it here live. So first of all, the determination if there is neuropathy or not. So there are sometimes symptoms that can look like neuropathy, but they could mean something different. You know, people can have arthritis, they can have spinal stenosis. So not necessarily any pain in the feet is necessarily peripheral neuropathy. So that's number one. Number two, if the diagnosis of peripheral neuropathy is confirmed, the question is this neuropathy related to amyloidosis or is it related to diabetes and so forth? So the neurologist in general would do specific testing. And usually the first testing that they do is to make sure the patient doesn't have diabetes, because that's one of the most common causes of neuropathy. Second is to make sure the patient doesn't have any vitamin deficiency, more specifically vitamin B12, because it's also a cause for neuropathy. And the recommendation is to check for that. And of course, screening for monoclonal protein that can also cause neuropathy. So once these tests are done, in general, the differential diagnosis of neuropathy will be depending on what the patient's symptoms are, the rate of progression of neuropathy, and so forth. So once, in my opinion, these common disorders are ruled out and the patient has TTR mutation, then it is very likely that the neuropathy is related to the TTR mutation and that the patient has amyloidosis. There's more evidence if there's also amyloid, autonomic dysfunction or carpal tunnel syndrome and so forth, and if the neuropathy is progressive, as we showed before. And at that point, if you have genetic mutation, you have the neuropathy, and the neuropathy is acting like amyloid polyneuropathy, and there are other organs involved, then you may not necessarily have to do a nerve biopsy. Especially if you have positive PYP scan, or the constellation of symptoms is very suggestive. But in case of doubt, and when you're not sure if the patient neuropathy is related to amyloidosis, everything else is fine, then you may want to obtain tissue biopsy. In general, I start with the skin and fat aspirate, and I may do a salivary gland as well. And if those are negative and my suspicion is still high, I would do a nerve biopsy. And I think the key point here is that one negative biopsy does not mean that the patient does not have amyloidosis. So I've had on several occasions had to do multiple biopsies to eventually find the amyloidosis. I hope this answers the question, but I'm happy to discuss further if needed or expand on certain points.
Thank you, Dr. Karam. The next question, if a patient has early cardiomyopathy and neuropathy, which drug would you use, tafamidis or Tegsedi?
Yeah, I think that's another excellent question, and one that also comes up quite frequently, particularly in the arena that we deal with in cardiology now, where we have more than one therapy that's available, but there are specific indications for all of these drugs, really. And I think it also highlights the importance that we need to identify the coexisting symptoms that occur in our patients that show up in clinic. Do they have neuropathy? Do they have cardiomyopathy? And what is predominant? Certainly there are other drugs available that is designed to treat patients with pure cardiomyopathy with wild type and hereditary TTR. But I think when you have that common scenario where you probably have a patient with a blend of both, for me, it really depends on what the predominant symptoms actually are and what is driving the particular patient's outcome or actual clinical presentation. So if we have somebody with a thickened heart muscle, but no symptoms of cardiomyopathy or heart failure, but they have significant neuropathy already at baseline, for me personally, I'm going to treat with a drug that is, going to be effective for the predominant symptom itself. I think it just highlights that every patient also is quite different in their presentation and their course. But this is a difficult call because of the fact that we do see patients with really a blend of both.
Thank you. The next question, is there a GFR or creatinine cutoff not to use Tegsedi in patients with prior kidney disease?
Yeah, I'll comment briefly on that. So I think just to highlight to remember the patients that were in the trial, first off, they were screened up front for proteinuria. So if there is more than 1,000 milligrams per gram of proteinuria at baseline, they are typically not enrolled in the trial. And I think it's important to note as during monitoring, they do in the actual PI, it mentions that if the GFR does drop under 45, ultimately it's important to withhold drug to assess for underlying glomerulonephritis. So I think that 45 becomes key when you have a patient on drug. It's important to hold and make sure that we're not dealing with an underlying GN picture and wait till that GFR climbs over 45 or you've safely ruled out underlying GN. And that's during the course of treatment itself. I don't know if you want to comment as well, Dr. Karam, at all, but that's typically how I approach.
I totally agree with your answer.
Thank you. And the next question, can you comment on cardiac endpoints, looking at the NEURO-TTR sub-analysis?
Yeah, so remember, once again, this was a trial where the primary endpoint was looking at the mNIS+7 score. So this is looking more objectively at neuropathic endpoints from a sensory motor and autonomic standpoint, and also neuropathy quality of life. However, there were secondary endpoints that were looked at, various different echo variables, including strain. But please remember that these were secondary endpoints, so the trial was not designed to look at this. I think that's very important. And certainly in those endpoints, there was no difference between drug, but I don't think we can draw a conclusion whatsoever about the impact on echo variables with treatment of the drug from this particular trial. I would also highlight in the 63 or 64% of patients that had cardiomyopathy at baseline, the drug was effective regardless if they had cardiomyopathy or not. So I think that's also important. And then finally, I think it's important to look to the future. I mean, we have ongoing clinical trials looking at antisense oligonucleotides and impacts on primary cardiac outcomes. So I guess we need to stay tuned if we want to get a little bit more effective data from that perspective.
Thank you so much, Dr. Darlington, Dr. Karam, and Lane. Those are the questions that have come in tonight. I want to thank everybody for attending Akcea's product theater and have a wonderful evening.